Hi, my name is Barry Make. We're going to talk today about expanding the definition of COPD. Expanding the definition of COPD. What do you mean we have a definition of COPD? Well, we do have a definition of COPD, but as a primary care physician, pulmonary physician, cardiologist, whoever you are, when you're seeing patients, you see patients who are cigarette smokers and they have symptoms, but you don't have spirometry. If you have spirometry, spirometry is normal. So what do you do with a patient who's got symptoms in normal spirometry? Or you have a patient who has a lung cancer screening CT scan and you find emphysema. Well, does that mean that patient has COPD or not? So we'll explore some of those ideas. Here are my disclosures. This is a CME. I'm not going to talk about any drugs or any pharmaceutical companies or device companies at all. So here's the current accepted definition universally, internationally for COPD, developed by the GOLD, the Global Obstructive Lung Disease Initiative, which has been in existence for almost 20 years. So the current definition includes these 5 features here. The 2 most important when you're trying to diagnose somebody with COPD is the second and the third. That is, it's characterized by persistent respiratory symptoms. The symptoms can be cough, sputum production, shortness of breath, wheezing, 1 or more of those, but the patient has some symptoms. The second is they have airflow limitation on spirometry. Now, persistent means that after a bronchodilator, it's still there, doesn't go away. So you need spirometry along with a history to be able to diagnose COPD. Of course, you need to exclude other diseases that may have similar presentations as well. So how do we go beyond that to describe the patients that I talked to you about that may not have abnormal spirometry, but may or may not have symptoms, may just have an abnormal CT scan? So we have a large study with 10,718 patients called COPDGene, the genetic epidemiology of COPD. We have over 400 papers we published in the last 10 years of the study. It's funded by the National Heart and Lung and Blood Institute. The goals are to determine the subtypes of COPD, because we just talked about some patients have symptoms, some patients have an abnormal CT scan, some don't. So it's not a homogeneous disease. There are many different small types of COPD, and we're trying to find out about those. And this discussion emanates from our findings in COPDGene. We're also trying to find a genetic basis for COPD so we can develop better medications to both treat and prevent it. And we're looking at longitudinal progression. We're now evaluating our patients over 10 years since they first entered the study, and we're planning to study them at 15 years as well. When they entered the study, they were between 45 and 80 years old. They were both males and females, pretty equally divided. We had 1/3 African Americans, which is very unusual for large studies to have that many African Americans, and we wanted to do that, and we've met our target of 1/3 African Americans. Now, to enter the study, the only criteria was that people had a 10-pack-year history of cigarette smoking or more. That's, and so we didn't enroll just COPD patients. We really enrolled smokers. So if you think about it, this is really a cohort of people who smoke, both currently and in the past. And that allows us to investigate things like what is a patient without airflow limitation with normal spirometry? What is that patient like? And should we consider that as some kind of problem? So we call that COPDGene 2019. That's when we describe this. And that's our new diagnostic classification for COPD with these smokers that I'll tell you about. So remember we talked about spirometry as the key feature for COPD in terms of diagnosing it. Now you see a red box here. First on the x-axis, you see FEV1 as a percent predicted. And then there's a line at 80%, because above 80% predicted is considered normal spirometry, whereas if you're below 80%, that's considered abnormal FEV1. Now, the real diagnosis of airflow limitation is the FEV1 FVC ratio, which is on the y-axis, and you see a line there at 0.7. So below 0.7 is defined as airflow limitation. The severity of the airflow limitation is determined by the FEV1, and you see these colors here. So the orange is gold stage 1 spirometry, the green is gold stage 2 spirometry, gold 3 is blue, and the pink is gold 4. Now that just describes the severity of the airflow limitation on spirometry. It doesn't necessarily define the severity of symptoms. So you see there's two colors above that are normal by spirometry. That is, they don't have airflow limitation. Well, I'm going to highlight something else here, and that's a group here which has a low FEV1, below 80% of predicted, but the FEV1 FVC ratio is normal. So there's no airflow limitation, but there's a low FEV1. This is a group that we found is very unusual. Most people don't talk about it, or they say, well, maybe the patient has a restrictive process and not obstructive process. That's not really correct either. These patients we found have symptoms, they have mortality, they have exacerbations, they have poor walk distance and poor quality of life. So this is an important group of current and former smokers that don't have COPD by the current definition. So what do we do with that group of patients? They have problems. So how do we incorporate that into a COPDGene 2019, which is our new diagnostic category? So in COPDGene, we have criteria here for our diagnosis. We start with exposure. That's the black triangle at the top of this graphic here, because all our patients had a cigarette smoking history of 10 pack years or more. Then you can see symptoms. Well, patients may be short of breath and they may have cough or phlegm. So we describe shortness of breath as an MMRC score of greater than 2. That just means they're symptomatic with their shortness of breath and they can't do their usual activities. Or chronic bronchitis, which is coughing and sputum production. And as we talked about, some patients have an abnormal CT scan, which you may see if you do lung cancer screening, for example, or the patient's in the emergency room for some other problem, gets a CT scan, and it's read as, wow, this patient has emphysema. So we determine structural disease in the lungs as having emphysema more than 5%, because up to 5% can be seen in otherwise healthy people. Gas trapping, that is, gas is trapped in part of the lungs, it can't come out because the airways are closed, or airway thickening. And then spirometry. Well, we define abnormal spirometry as either classic abnormalities we talked about in terms of airflow limitation, or those PRISM subjects. So putting these 4 features together, we describe COPDGene 2019. Now, if you think about it, when you take these triangles and put them all together, you have a group of patients that just have exposure, only cigarette smoking. So those patients are a reference group. Then if you add a CT that's abnormal, exposure plus CT scan, you can have a group that's exposure plus symptoms. So you see we have progressive abnormalities here, combining exposure with either symptoms, spirometry, CT scan imaging, or some combination thereof. Now, if you're thinking about, well, are these different groups important? Well, why would you think they might be important? What would you think of as an outcome that would be important to you and the patient? Well, I venture to say that if patients die, that's a significant poor outcome. So here we look at the hazard ratio for all-cause mortality. Our exposure only, cigarette smoking only, with no other abnormalities was our reference group. As you can see, as you add other abnormalities, the all-cause mortality goes up. So for example, exposure plus symptoms, either shortness of breath or chronic bronchitis, 1.55 for the all-cause mortality hazard ratio. And it goes all the way up to 5 times the mortality in patients who have exposure, cigarette smoking, symptoms, either chronic bronchitis or shortness of breath, abnormal spirometry that I told you about, sort of the PRISM kind of abnormality, plus the CT scan, 5 times the mortality of people who only have exposure to cigarette smoke. So we call this group here, with the 5 times the hazard ratio from all-cause mortality at the bottom of that table, definite COPD. We have a group that we labeled probable COPD because they have increased all-cause mortality, but it's not quite as bad as that 5 times. It's only about maybe twice normal. Okay, then there's all-cause mortality, only about 1.5, that we call that possible COPD. So you see, putting these features together, we're hoping to be able to help you find patients with abnormalities to come in and present to you with symptoms and say they're not healthy. So we had a paper that we published once, and we wanted to call the paper "The Myth of the Healthy Smoker." this sort of puts that in some perspective, right? Smokers are not necessarily healthy, even if they don't have COPD. Now, what about another outcome which you might think of as being really a problem for these patients? Well, it turns out it's spirometry. So we talk about disease progression. One of the things in terms of disease progression is whether or not the spirometry becomes more abnormal over time and the FEV1 is decreased. Well, everybody's FEV1 decreases as you get older. Whether you're a younger person or an older person, your FEV1 declines. And it doesn't usually decline more than about 50 mLs per year. So we said, well, significant decline, if people decline an average of 70 mLs per year over 5 years, 350 mLs over 5 years, that's a lot. So we took these same groups of patients with either exposure or cigarette smoking plus other abnormalities we discussed in that diamond figure, and we said, what are the odds of them decreasing their FEV1? So our possible COPD patients here have a little increase in their odds ratio of their FEV1 change. Our probable COPD much more, and our definite COPD almost 3 times the odds of decreasing their FEV1, having progression of their disease as defined by spirometry. Now, the interesting feature here is that abnormal spirometry is least associated with the FEV1 decline. So you really don't need spirometry. If you look at the groups with abnormal spirometry, cigarette smoking history plus abnormal spirometry, they don't really have an increased odds ratio of decreasing their FEV1 and progression. If you look at people with exposure plus symptoms plus abnormal spirometry, they also don't have an increased risk of decline in their FEV1 over 5 years. So it shows you that FEV1, again, is not the most important metric for defining COPD. So in summary, we have this interesting new diagnostic classification of COPD called COPDGene 2019, which we hope you'll be able to use in your clinical practice to find patients who present to you with symptoms or abnormal CT scans to try to think about how to manage them. So what's another poor outcome that you might think about and want to know about? Well, you want to know whether the disease progresses over time. So we looked at the odds of changing your FEV1, reducing the FEV1, progressing your disease by 350 mLs over 5 years. Now, normal decrease in FEV1, where you all get older and our FEV1 declines over time, about 25, 35 mLs per year, up to maybe 50 mLs per year. So this is a 70 mL decline in FEV1 over time. This is progression of the COPD. So again, we took our group who just had cigarette smoking exposure, they're our reference group, and then we added again the groups that have more abnormalities like exposure plus symptoms, smoking history plus abnormal CT scan. So you can see with an abnormal CT scan or symptoms added, there's a higher odds ratio of your FEV1 decreasing over 5 years, and we think that's still appropriate to call that group possible COPD. Then in our probable COPD, you see that almost goes to twice the odds of decreasing your FEV1, having progression of your COPD over 5 years when you add these other categories. And our definite COPD at the bottom here, when we add cigarette smoking history, symptoms, abnormal spirometry, and CT scan, is almost 3 times the odds ratio of progressing the underlying disease and the physiologic abnormality associated with cigarette smoking. Now, what's interesting also in this slide, I'm going to highlight a couple other areas, is that an abnormal spirometry was the least associated with an FEV1 decline. You see, when we add cigarette smoking and abnormal spirometry, it doesn't change the odds of decreasing your FEV1 and progressing over time. If we add exposure, cigarettes, symptoms, and abnormal spirometry, those 3 together, you can see your odds of changing your FEV1 does not increase. So abnormal spirometry is the least associated with a decline in FEV1 over time. So in summary, this is a new way to look at patients who come in with a history of cigarette smoking. Think about symptoms, CT scan, and spirometry in a different manner than you would in the past to define patients as no COPD, possible COPD, probable COPD, or definite COPD. Thank you.